And today we're going to talk about gastroesophageal reflux disorder and how we deal with that. Hi, I'm Dr. Mona Morstein. Welcome to my channel. I've been in practice 36 years. If you're not a subscriber, please click the link below. Otherwise, let's get started. Gastroesophageal reflux disorder, or I'm going to call it GERD from now on. This is a real problem, right, in our society. Heartburn by itself is the feeling like in the stomach, in your esophagus of a burning type of sensation. And many people here and there overeating or eating something very spicy now and then feel some heartburn. But GERD is the more serious chronic condition where this chronic acid in the esophagus can actually damage the tissue there. And unfortunately, it's pretty common. Approximately 20%, like literally 1 out of 5 people in the US has GERD. What is GERD? So the anatomy of this condition is that it consists of the stomach, where the parietal cells make hydrochloric acid, and the esophagus, where our food goes down. And then in between is what we call the lower esophageal sphincter, which separates the esophagus from the stomach. Now, generally, when we eat, that lower esophageal sphincter is supposed to close up. So while the stomach is churning and digesting the food and making acid for all of that, it doesn't go through the sphincter. So the main disease of GERD is a weakness in that lower esophageal sphincter. So acid will come up through and harm the esophagus, which is not designed to have any acid washing against it, right? So the stomach has cells, these columnar cells and goblet cells, and the goblet cells make mucus to protect the stomach lining from its own acid. Well, the esophagus is squamous cell, kind of like your skin. But when it gets acid coming up over and over chronically, it's going to signal the cells to change and to develop more columnar, well, not to develop more, just to develop into columnar and goblet cells. And that's called metaplasia. It's a change of cells. But if the cells start changing, sometimes they can't stop changing. And if there's still more and more acid, it can go from metaplasia to dysplasia, which is kind of precancerous cells, to actual adenocarcinoma, esophageal cancer. So that is now the intermediate one is kind of called Barrett's esophagus, which is when the cells have changed, but they're not cancerous, right? What are the things that loosen that lower esophageal sphincter? Well, a hiatal hernia can be involved with that. Interestingly, either too much acid, which can happen in our younger people, where there's just so much acid, it can literally just get through, or not enough acid, which is what tends to happen as we get older, that the lower esophageal sphincter is sensitive to acid production. So if we make 100% of acid, that's going to close the sphincter. But what if we only make 50% of the amount of acid we're supposed to? Well, then the sphincter may not close all the way, and even that lesser amount of acid can get through. Being overweight or obese, like pregnancy and just being overweight or obese, can put that pressure above that pushes the acid north. Tobacco can loosen the lower esophageal sphincter. And now, also, we're going to talk about food sensitivities, which I'm going to talk about later. And there are other foods that can just irritate the situation, like coffee, peppermint, tomato, citrus, spicy foods, chocolate foods, fatty foods. So those are all foods that tend to make the GERD worse, right? Now, how do we diagnose GERD? Well, obviously, people can have signs and symptoms. They can certainly have heartburn. They can also have regurgitation. They can feel a lump in the throat. So a lump in the throat is oftentimes associated with GERD. People who get this dry kind of cough, especially after eating, because the acid can actually get into the bronchial tubes and it can cause coughing and actually asthma. In fact, asthma is a negative side effect for sure of having GERD, both in kids and in adults, particularly. Oh, I wake up with asthma in the middle of the night. Well, that's when you're laying down and all the acid can just go up and into your bronchial tubes. There can also be just a sore throat. There can be hoarseness. There can be a bad taste in your mouth. You can have dental problems because it can wear your enamels off. And it can also start hurting to swallow. So these are kind of symptoms that people have. They're obviously going to do what's called an EGD, which is endoscopy, looking at the esophagus, the gastric area, and the duodenum. And they can see if acid is coming up. They can also diagnose Barrett's esophagus by the way the esophagus looks. Now, there are some other tests. They can do a pressure test of the lower esophageal sphincter and pH monitoring, but they never really do that because what's the main thing they do to tell you if you have GERD? They say, go try a PPI, which we'll talk about in a second, but just try this medication, this PPI, this very strong antacid, and see if it helps your symptoms. Oh, it did. Okay, guess what? You have GERD. Okay, so that's what they're generally going to do. And the problem, that is a big problem, right? Because conventional care of GERD is suggesting you get weight loss, telling you to sleep kind of at least 8 inches, above flat on your bed, and then giving you the proton pump inhibitor, as well as telling you to eat those foods that I just mentioned, eat small, frequent meals, which is not really what your gut wants you to do. And then when you eat, to sit up or not lay down for at least 3 hours, right? Or don't even bend over and stoop. Those are bad things. The medications, there are just antacids like calcium carbonate, that's Tums, although aluminum or magnesium hydroxide, and aluminum is kind of poison, right, associated with dementia, so we don't really want to do that. But these are the most mild of antacids and are really only used for those patients who very rarely have a heartburn episode. Otherwise, there are what we call H2 receptor blockers, which is classically something like Pepcid, which will block about 70% of the acid. And then there's the proton pump inhibitors, and those will block up to 97% of acid. And there's a huge problem with proton pump inhibitors. They were invented just to give to people who had an ulcer, a stomach ulcer, to help heal the ulcer. Then they were discovered to stop GERD and heartburn. And so that's how they're dosed to nearly everybody. And there are really big discussions in gastroenterology. About 50% of prescriptions are inappropriate and they should not be used. That's why it's the most widely used drug around the globe. But what does it do negatively? PPIs do a lot of things negatively. They reduce the absorption of B12, calcium, iron, magnesium, and vitamin K. They increase the risk of fracture. Well, you're not getting your calcium in. They increase gallbladder disease, kidney disease, pneumonia, food poisoning, your risk of getting C. difficile, your increased risk of all different kinds of pancreatic cancers, having an enlarged liver, getting dementia, like the bad drugs, bad drugs that people are dosed and told just to stay on forever. And if the drugs don't work, then they'll do one of 2 surgeries, a fundoplication, where they sew the stomach to the esophagus, or a technique called the links, where they put little magnets at the top of the stomach to keep it closed. Unless, of course, they could just say, well, you're overweight, it's causing GERD, why don't you have some bariatric surgery? That's what happens with regular conventional care. How do I treat GERD? It's generally not that difficult. First I'm going to do is a food sensitivity test. By far, that has been my #1 test for patients in 36 years of practice for those who have GERD. Because if we find the food that your body says, I don't like, we pull that out, the GERD will definitely settle down. And not only will it settle down, but then you can have coffee and peppermint and tomato and citrus and etc. Those foods just aggravate an annoyed system. But when you get rid of what causes the annoyance, annoyance, then you can go back and eat and drink those foods, right? So I do 184 IgG subsets 1 through 4 through a company called Alates. That's who I use. I've used them for over 20 years, completely trust their results. We can also analyze for stomach acid, but one thing clinically, if you have low stomach acid and you eat a piece of steak or chicken, it just sits in your stomach like a rock. And that's a very good clinical symptom of low stomach acid. There is a Heidelberg machine that does that, but those are difficult to come by and they're expensive. So if we think that low stomach acid is involved, then we can dose apple cider vinegar, gentian, botanical, and other bitters, which you want to put in your mouth. You want to taste that bitter, but that stimulates hydrochloric acid. It stimulates bile. It just helps the whole digestive system. We can also then, if we need to, give hydrochloric acid. But sometimes I like to support the person so that they make the hydrochloric acid they need instead of I just dump it in them. And it's dangerous to dump in seniors because it can easily cause them to have an ulcer if you're overdosing it, which you should never do. Hydrochloric acid, 1 or 2 per meal, that's it. I can talk about that in a later visit. That's it per person per meal. Otherwise, we give soothing herbs, slippery elm, marshmallow, aloe, licorice or DGL type licorice, N-acetylglucosamine, zinc carnosine, plantain, chamomile, mucin, ginger. All of these are used in various products. I use a product, I use some slippery elm tea by itself or marshmallow tea, and then I use a product that has the slippery elm and marshmallow and plantain and the licorice, the DGL in it. And people take that about 10 minutes before their meal, and it works really great. And in this way, we can naturally treat people with GERD and not get them on PPIs or get them off the PPIs that they've been on for a long time in a very, very slow weaning process. You cannot just stop your PPI. It has to be slowly weaned off. But this is the way we're finding out what is driving your GERD. Then we remove that, heal the lining, heal the gut. There are even ways to heal Barrett's esophagus, which I can't talk about right now, but a lot of nutrients can help heal that tissue. And so it's really great. If you've got GERD, which is common, come seek a naturopathic physician to really help eradicate that and get you off of problematic medicines. I'm Dr. Mona Morstein. Thanks for listening. Just click on the link below and it'll be 1, 2, 3. Take care. I'll hope to see you again.